Well, I think that's all from my side. Anybody else? Anybody? Any of you can unmute? Dr. Parul? Well, fabulous. I don't think there are any questions because nobody else of us has even seen such kind of surgeries.
So to give you some leads around before we come to a close later, is that Dr. Kiran, this is a little challenging surgery when we are on table.
Yes.
I have operated in close to 9 or 10 workshops, all by gynecologists who had cases, and they said, let's pitch in one and learn something. And believe me, all those 9 and 10 gynecologists have actually done more than 2 to 3 cases after the workshop. So it's all about when you see it or when you do it, and I stand by the side and assist. I think it feels quite empowered. Number one. Number two is one must not forget the medical treatment of it. Surgically, we all want to be good, better, and best. But the medical treatment, because majority of them are hormones. So when you see a clitoromegaly, let's not jump into it. We slow down our pace. We give them a lot of hand holding and hug and say that this can be sorted out. Let the medical guys look into it once. And the hormone guys are very good. Endocrines are very good, both pediatric and adult endocrines. And they look into it from the understanding point of view that we're not missing out something. That means there could be tumors, there could be isolated just a growth, a tumor of the clitoral body, a tumor of the ovaries. All those things can be there. So sometimes it can be a local presentation, sometimes a systemic presentation of a hormone related change. Other than that, it's quite technicality. It's all practice makes you perfect. The more you practice, the better you are. Number one. The other thing is, if you always do what you always did, you will always get what you always got. So therefore, it's time that the kind of program that you're running. I've not seen the entire program. I feel very good that you've taken this gauntlet of training our colleague, young gynecologist who could be the future of this country and take this subject which I've mixed out. I also want to tell you that I do master classes in urogynecology. I've slowed down that only because of things. But everything right from what a gynecologist needs to know in a friendly neighborhood called uroflowmetry to urodynamics to overactive bladder to refractory overactive bladder to a stress incontinence part where biofeedback could be a part of it, apart from just telling them Kegel exercises. And then coming to the other aspects, which is all about recurrent UTIs, that I love talking sometimes. Maybe one of the, Kiran, I've spoken in one of your sessions long back.
Yeah, yeah, I know that. I know that. Yeah.
So it'll be great to start a urogynecology session, and I would like to pitch in one fine day. I'll request Dr. Parul to coordinate, and we'll have one Sunday where I've got a list of 21 topics to be taken as case based. No theories, please. There will be photographs. There will be a case, and then you could question answer, and then we could do it. You will enjoy this. I've done that with Nepal. I've done that with Serbia. I've got the entire cases. It's lying in one of my laptops. Yeah, because you're doing a wonderful training practical session. So I've got case-based gynecological work around, or maybe in one of the
Well,
conferences you do.
since you have already, it's come from you, it is done. So you just have to coordinate with Parul, and I guess Parul and Dr. Renuka Alsi, who also is doing urogynecology in Aurangabad. I think both of them will coordinate. And one fine day, I mean, I guess that you are going abroad, so that's why you're not available on third. So that is what has been given to me. So whenever you have time, you just have to drop in a message here, Kiran, I'm free on so and so date, and it is done. Just give me a notice of 124 hours.
So I will let you know, Dr. Kiran, you got to be around when we do it.
Yeah.
They told me Dr. Kiran is around, and I felt very good, submerged around. I've done 3 robotic surgeries today. I did a transplant today. So the day is done. I normally work 15 to 18 hours. I
I know
enjoy
that.
this. I was
I
very happy when she showed 9 o'clock. I said the day is great.
Dr. Kiran sir, we had sir for the AI, the AGL at Mumbai 2 years back, where he spoke on Botox for overactive bladder.
Yes, yes, I remember
He
that.
had coordinated. It was an excellent talk that time also.
Wonderful hall, great camaraderie. So I always say we are partners in pelvis, and I keep learning a lot. I'm very selfish learner, whatever happens around. That's 25th year. So maybe one of the
Amazing
conferences.
videos and amazing surgeries today. Thank you, sir.
So we need to come back to your conferences too. But I will plan this out. We'll keep it a Sunday where you all can join in for a while, and we'll keep it completely case based. You'll remember this for your lifetime, kind of thing. Around.
Sure, sure.
Friends, thank you so much.
One of my friends who works with you who speaks of very high regard about you. His name is Dr. Nagaukar. So he speaks quite high about you. Anyway.
That's good. It's good. It's great to be here, sir. Thank you, all of you. Thank you very much. Great. I'm glad you all doing this. I wish I could do it for urologists, but I should still, because unfortunately, I mean, I shouldn't tell that. Unfortunately, a lot of deep reconstructions have actually been missed out in our country right now. There is one girl, just believe this. There's one girl whom I'm operating next week who's undergoing a surgery called Mitrofanov plus MACE. Now, understand this because girls, you will see. There's a girl who has got a neurogenic bladder and she got recurrent UTI. One kidney got knocked off, so I removed that kidney. Now, she has got a bladder which is completely gone. She cannot pass urine and she has got a catheter indwelling. We remove the catheter, she goes into massive UTI and the opposite kidney suffers pyelonephritis. She passes bowels once in 3, 5, 7 days. So she has got a bowel not moving, she has got a bladder not moving, and she was one of the most beautiful young girls I've seen at the age of 13, 14. 11 such girls I've operated, and she's going to be the 12th girl at the age of 13. Now, what happens, you need to know. When we do this, we create a Mitrofanov, which is a self-catheterizable stoma, which is a continent stoma. So we increase the bladder capacity to adult internally from the intestines and give a very hidden kind of, I'll show you those pictures when they come to masterclass. And that is a hidden stoma. The husband cannot identify that under the umbilicus there's a hole. Number two, I create another small hole, an opening at the level of cecum and make it a catheterizable stoma. So this girl who is not passing motions once in 3, 5, 7 days, even with medication, now early morning, the mother puts a feeding tube and 100 ml of saline or warm water from the tap. It works as an anti-grade enema, and the girl goes after half an hour and passes all the motion right from the cecum all the way till the whole colon. She gets a catheterization now because the bladder is an adult bladder. We catheterize her at morning 6 o'clock, afternoon 12 o'clock, evening 4 o'clock, night before she goes to sleep. And this is done by a mother. Later on, the girl picks it up. Now, what happened is the story goes like this. There's one lady whom I forgot. I'd operated her in 2008 in Chennai before I came to Kokilabin Hospital, and I forgot about her. And the director of AIMS Gynecology called me up and said, Dr. Pandey, there's a girl whom we operated 17, 18 years ago. Now she's pregnant. I said, why am I called? Show it to Rajiv Kumar and my colleagues in AIMS Delhi. They will handle it. So Rajiv has said only Sanjay Pandey should handle. Send her back to Bombay. The story here is she has got a bladder anteriorly and she has got a uterus posteriorly. The bladder has been made by a doctor called Dr. Sanjay Pandey, where there is some vessels coming from the top. The vessels come from the intestine, and the bladder has been made that. So for the last 29 years, she actually was doing a catheterization. She got pregnant, she got married, and now she has got a uterus just behind that. Now, if you want to have and she's a very short lady, she cannot get a normal vaginal delivery. She's also a diabetic, so expectation is she will have a larger fetus. Now, the gynecologists are in trouble because if you need a cesarean section, you have to go through the bladder. The bladder has got its blood supply coming from the viscera up there. So, all I have to do is I have to open the bladder, anterior wall, I have to open the posterior wall, and then expose the uterus to her for to take an anterior uterine incision, get the baby out through the uterus, through the bladder, and then she repairs the uterus, I repairs the posterior bladder wall, the anterior bladder wall, and then it comes out. So I know what a harakiri I did for that patient. She anyway did this, and I've called up all the patients I've operated, the 13 or 12 girls, and said, please don't get pregnant anymore. So it's a scare. So much, so much of stuff we'll talk about when I come to this masterclass, case-based kind of thing.
Sure, sure. Would love to be with you again. Thank
Thank
you.
you.
Thank you so much. Thank you for your time and thank you for that generous gesture of that masterclass. Renuka, I believe you will be excited in having sir again on this masterclass, right?
Very much, very much. Actually, very much.
Welcome. Okay.
Thank you, Dr. Sanjay.
Thank
Thank you.
you. Bye-bye.
Thank
Good
you.
Yes,
night.
yes.
Bye-bye.
Thank you, sir. Thank you, sir.
Thank you.
Thank you again.
Call it today. Bye-bye. Thank you.